a leader who has risen in her career as a practicing internist, who has influenced and led design inside Center for Medicare and Medicaid Innovation Center, CMMI, which I believe gives her a rare perspective on how policy is not only designed, but can take into action in healthcare delivery. A national speaker on digital health, healthcare delivery, mental health, I believe, recently affordable care and trust, and many, many more topics in the ecosystem of healthcare. So thankful to have on the executive uninterrupted Chief Population Health Officer of UC Davis and an aligned role with population health across all UC Davis sites is Dr. Reshma Gupta. Dr. Gupta, thank you so much for joining me today.
Great. Thanks so much for having me. Excited to talk and share a little bit about what work we do and the exciting kind of journey that we've had.
It's so interesting because in this particular show, we've talked to a variety of medical officers, I would say health tech scientists. They all have the discipline and background of medical science in their background, but we've yet to have a true pop health, I'd say, passion focused and mission led leader as a voice on our show. So I'm particularly excited that you're able to join me for a little bit today. And I had mentioned to you before we began the recording here, I feel population health as a discipline itself is on perhaps its fourth iteration
Mhm.
and still has its roots in clinical practice and policy, but it's gone through SDOH and data initiatives, equity initiatives, and is spanning outward in the ecosystem with digital health themes as well. And it's just so fascinating to see where it's going. And I know you've seen those iterations in practice throughout your career in different settings. And I'm curious, going back behind the titles I just mentioned, and even your residency and your entry into corporate, maybe more of a corporate style career, what interested you in population health? Did it start there or did you naturally come to that place?
Yeah, I'm going to bring it way back to kind of
Good.
just like what growing up was and what was priority, because I think it actually explains almost everything I've done.
Mm,
And I really appreciate how you just described that, because I think that the bottom line is what drove me to population health is being mission driven in how we deliver healthcare. And I think that's the piece that often gets missed when we're like chasing that shiny object. And I think that's also how I've kind of learned over my journey why things fail, why pilots fail. It's because we lose
mm,
track of that. And if we get back to that kind of
mm,
essence of it, everything makes sense. And that's how we move the needle. So for me, I kind of take it way back. So my mother was probably one of my biggest influences, from like growing up. So she's a social worker in India who actually worked in the poorest kind of slums and areas of Mumbai. She worked in stigma and TB and leprosy. Like that's kind of the work that she did. So she came to the US in the 1970s and focused on immigration, assimilation, acculturation, those
mm.
kinds of topics. And basically for 40 years worked between St. Louis, Brooklyn, and the
Oh,
Midwest and
wow.
Wisconsin, all very different areas, all different demographics,
Oof.
as a social work professor. So when my sister and I were growing up, we learned all about those structural reasons why communities struggle, if that's education, healthcare, whatever those social needs are, kind of what you were just mentioning firsthand. I mean, I remember going trick or treating in Wisconsin with the Hmong community refugees that she was building programs
Wow.
with. Part of her program, we would just do it together, and they were learning English, and I'm eating new foods, and it was just normal for us to do that. And then,
Fascinating.
yeah, and then when they moved to California, kind of in post retirement, she went back to work because she couldn't stop, and actually worked in the school system training social workers. Right, totally different group of population in California. So that is my like lens and framing for everything
Mm,
that I pretty much do. My father is an engineer, and thus I get like the hard science part that made me a doctor. But
oof,
people often say you combine the engineering scientist and that social worker, and you
oof,
get a socially
oof.
minded physician, like a mission driven physician. That is me and my
I
sister,
love that.
right? That's essentially how we landed where we are. So I think my own journey beyond that then is like, how did I apply that? I've worked in rural and urban areas, mostly on the West Coast, but I've had spats where I've worked internationally. And for a while, thought I was going to do international work in Africa, South America, and in India. But I was really focused around, like, early in my training, learning around new community health worker models, like how to
Mhm.
address chronic diseases or HIV or whatever it might be. But in these areas where we don't have all the money in the world, but yet they've been able to move the needle. And what I
Yes.
realized from that was there's two big lessons that I learned. How do places that literally don't have resources can innovate and move the needle? And what are lessons I can take from those places and bring them back here? Because as we get into budget issues and all of the concerns that we have around healthcare costs, why is it so hard for us to do that? Right? When there's groups that obviously are able to do it somewhere else. I think the other thing is there's a really common sense approach that care delivery design has that I gained from those experiences in that background, which is that you don't always need the most expensive thing to fix a problem. What you need is a really straightforward workflow, understand your patient population's needs, and then bring that scaled with technology and kind of devices as you're able to pull them in. That is literally verbatim what my day job is now in population health. And so those are the kind of lessons I think that really put me back into this work. And I think the biggest kind of lesson that I keep trying to bring home and I still struggle is that the most innovative ideas I've found through all these experiences are in the pockets that we never look. They're not the people publishing it. They're not the people that are out at all the conferences even. They're in, like, the rural parts of Wisconsin and Minnesota that I've been in. They're just villages abroad that do work because they're just focused on who is my community, what are their needs, what makes sense with whatever resources we have, and let's get it going and build a community to execute it. That is my basically platform for everything I've done since then.
Wow. And I have to tell you, Reshma, first pitch home run. And I knew it was going to go this way, but I am just blown away. And this is why we have these conversations and why we say uninterrupted, because for the platforms that you speak on in a national sense, conferences, other media, looking at the person is so critical to understand why you've chosen a particular discipline and why you are so uniquely tied to making a meaningful impact, not only for the populations you serve now, but maybe in a generational sense as well for other communities that are coming through where you make an impact and other physicians, other population health researchers and scientists out there. And the most unique thing that I can take away from this opening comment is you are of the modern era in population health. And I think because of your experiences, many people say lived experiences, you
Mm,
saw so many different pockets of cultures of health in your childhood, and how fascinating that is to get those repetitions and experiences, even down to the comment you made about trying new foods. That will bring you into someone else's
mhm.
perspective immediately and help you translate what's happening in their world. So I'm so thankful that you quite literally knocked it out of the park. Modern era pop health style. So you clearly had several inflection points that I picked up on there, and I'm curious, were you seeing your best impact as a pop health leader during medical school, during practice? Was it later on that you realized, hey, I've seen these things and I can build different programmatic solutions that are tied to payment and access?
Mm.
When did that happen for you?
Yeah, that's a really good question. I think retrospectively, like, everything makes sense, right? But when you're walking through it, you're kind of just going through the forest and not really sure what to call
Mm,
things. So I think I knew what was important to me, right? And I knew what felt right and what kind of groups and initiatives felt like were chasing the wrong thing. Like that, I had a spidey
mm,
sense for that, but I don't think I had the right term for it. So when I was training, I was gravitated to certain clinical groups that thought holistically, that asked questions about the
mm,
patient's experience, where they came from, that was concerned about the areas they lived in, what resources they had, and what was happening outside the walls. for me, that was like pediatric asthma, HIV clinics, cancer centers. So then I thought, well, obviously, I must be interested in the disease. I should be an oncologist or an
Mm.
infectious disease doctor or a pediatric, right? Because that's the doctors that,
Natural. Yeah.
I saw. And then what I realized is I don't think that's it. I mean, I still do like I nerd out on the clinical stuff, like I'm a physician, but that's not the thing that was really motivating me to stay up or like write and really, really connect. It was the approach they had. And I think I didn't understand that till I
Yes.
actually finished my clinical training. And I was
Mm.
in my chief residency year in Seattle, and a mentor of mine basically told me, "What are you interested in?" And I just couldn't come up with an answer I believed in, but I knew I had like a lot of passion.
Mm.
And it was around that time, right? Affordable Care Act was being written. And I was just like, I had the mental space maybe after training to say, I need to do more than the same problems I see day in and day out in our medical center. And
Yes.
how do I apply it? Like, where do I put myself into the advocacy spectrum? And that got me interested in policy, but I also wanted to be able to tell the stories of those communities, right? That come back to my background. But in medical training, you don't get all that training. And I went down to do a Robert Wood Johnson fellowship, basically. And I went down to UCLA to get that training. And from that training, that's where my first interaction with CMMI happened as a fellow. That
Mm.
then I finally could say, wow, okay, this is a piece that I can dig into. And I think the timing was right because the Affordable Care Act was at the door and there was money to kind of think in a population health method. There's amazing leaders in the organization that I think had a similar ethos, and I could finally put a name to it, population health.
Mhm.
So then started really researching, well, what does that mean? And what kind of job is that? And what does that look like? And just talking to a million people. And kind of similar to you said, population health, even to this day, means something different to every single
Yes.
person in every health system you ever talk to,
Yes.
even within one organization. But I gravitated to those people that were maybe more community based, maybe didn't see population health is just the managed care group trying to meet the contract goals, that it's about a community, it's about a population, it's
Mm.
about being at the strategic table to make decisions for the organization based on the data you uniquely have that tell the story of the
Mhm.
community, which is not actually accepted probably in most medical centers. But those that are, that's what attracted me. And that's what actually brought me to Davis because our institution is a land grant institution. It's the only EC campus academic center, but we're in the state capital next to policy. And we're
Mhm.
also
Mhm.
a land grant institution. So we, by definition, are committed to the community. We're an anchor institution. We hire locally, we train
Yes.
locally. All of
Mhm.
that ethos, right, then comes together to be able to say, in this mission driven way, can I have the space to lead and execute in that way? And that I think has brought me kind of like full circle and what
Yes.
got me interested in this. But along that pathway, I got to see it from a lens of what does that mean in policies that could support this work? What does it mean in
Mhm.
alternative payment models, which is where most of my work was in that space? What does it
Mhm.
mean to design a program at a health system level? What does it mean to implement it? What does it mean to evaluate it? And where are all those different lenses in building that skill set?
I think that's fascinating. And as you were saying that, Reshma, I was thinking about
Mm.
the guerrilla approach of population health that your mother had serving different communities and very
Mhm.
tactical and community level. And that is an important experience and lens to see through. But how do you take that and put it into a policy at a federal level that will require organizations, health plans, healthcare systems, states to adopt certain processes, procedures, and build programs out for access to ensure certain populations have certain things. And I think that is just like such a, I'd be remiss if I didn't comment on that because I
Yeah.
see that in your approach. And it's so interesting. We have to brand everything, especially in the United States. We have to brand something and that it has to mean something. But you've always had that philosophy of what we entitle a
Mhm.
population health leader. And I'd also be remiss if I didn't ask, you mentioned your sister. So I don't want to assume, but obviously your sister has had to have some significant accomplishments
Mhm.
come from her childhood experiences as well. Can we drop a shout out to her
Yeah.
in her work? Is she in healthcare as well?
Yeah. So we're both internal medicine physicians, both, I would say, socially minded. I went into international health and kind of came back to do a little bit more domestic work, and she's kind of had the opposite route, but overlapping. So she actually works with an amazing group that does global health work in chronic disease. does a lot of work with the WHO,
Wow.
but then also sees primary care patients in the Bay Area, as you know, and so we're still practicing.
Wow.
And so I think it's fun because we get to kind of live each other's worlds out with like two different jobs in a sense and kind of live both of them through each other. But it all comes from that same, what's priority. And I really like the way that you said it. So sometimes when I get a new job, you come in an organization, they'll say, "Can you give this talk on population health?" And the first thing you have to do is define what population health is because no one says. And what I always say is population health is a perspective and an approach of leadership.
I love that.
Yeah, and it's
I
almost the same
love that.
words, yeah, that you were using because for me, it's an approach that's really refreshing because it's a leadership style that's prioritizing meeting patients' needs where they're at, planning strategy and investments that use common sense, leverage data, community insights to meet those needs. That's it. That's what we do. So it's not based on a service line, it's not based on some ROI specifically. It's what are the community needs? What are related to healthcare, that are generally in the well or health, right? Upstream and we have to tackle those. So now I got to make the ROI business case to do that, but I'm bringing it from our patient needs, right? It's not the reverse of it. So wherever you go, if you can know how to use data, if you know how to access that, the patients will tell you the story of what your work is meant to be, for those next 10 years.
Beautiful. And I got to go back. True modern era. It truly is. And we needed the traditionalists to get us to where we are now in the population health definition that you had shared. I'm just so blown away of your approach. And something else that you said just a little bit earlier in your early experiences and when Accountable Care Act was coming into application in the United States, and eventually it grew to cover almost 30 million Americans in a few short years, and it helped bridge access in the most affordable way at that time. And it made me think of, in my days, I was with Cigna for many years, and we did not have a pop health or pop health philosophy approach to the way that we are contracting our network in terms
Mhm.
of how we can apply pay for performance and eventually get to some sort of sub capitated or global capitated arrangement, which looking back is just bonkers. And at that time, I think it's very objective for me to say we didn't apply the help to the physicians that we were trying to push into performing better. We didn't give them the stuff that they needed. We were pushing on contracts. And that wasn't right. But those lessons learned has helped large organizations like a Cigna and beyond evolve to have more meaningful provider connections and hopefully will continue to do so. And thinking about those programs and how rudimentary they were, I mean, caveman-esque. And fast forwarding now, what programs have you developed of late that you're very proud of, or you're seeing meaningful measures of success early on?
Yeah. So I'm going to share a few, but I want to share one of because I'm actually doing what I learned when I was a lot earlier in life and now I'm bringing it here. So
Ooh.
one of those things, because you mentioned it earlier, so I'm pulling it back, is when I think about like what I've seen in the content, like the innovative stuff that I've seen in these communities that are like local, but never, they never write about their stuff. People don't even know what they're doing. One of the
Excellent.
biggest ones I thought is working in communities in California was around this effort around food as medicine and kind of traditional food
Mm.
and wellness, which has now
Mm.
exploded over the last few years. But this is before that even happened. It's like decades before. But communities have been thinking about traditional foods and culture and how they intersect. And so it's not the academic way of looking at, food is medicine and we're going to give food to help this diabetic population. And it's this very regimented kind of thing. All of that's good. Oh, that's great to have kind of that evidence. But this is like telling the story of how to actually get people to use and make the behavior change of healthy foods, which is much harder. And from a lot of that, I took stories from the community of, food brings cultures together. They call breaking bread, right? It brings families together. Like food is the center of what gets people talking on the phone, events in the communities. And within these communities, if we suddenly kind of have this very academic way of saying that food, for example, has been really unhealthy, we're almost saying to people, your tradition and your grandmothers that made that food were harming you, which is like the literal opposite of what we need to be saying to get people to
Yes.
actually change their behaviors. So one of the biggest initiatives I've been probably most proud of in the recent, let's say 5 years where I'm working locally is a food ways to health. So it's not just a very
Oh.
medicalized name, but a food ways to health which is a regional food system. So it's like, you think about it, we spend $1.1 trillion in this country on
Yes.
diet related health conditions, some of the
Yes.
conditions I mentioned and others. But imagine putting that into food instead of just the medications that treat it as sick care, right? Instead of
Wow.
preventative care, wellness care.
Wow.
And
Wow.
so we've actually built a system with our chef, me as in population health, and our equity lead, our associate vice chancellor. And so you got a group of people who are experts in using data and leveraging the system and the population. And I know all the registries of every patient that has every medical condition. You got the person who's out there who has decades of history in the communities, who has a team who's grown up in these communities, who knows the stories and knows what flies and what's flopped. And then you've got the person who knows the entire culinary industry, all the ranchers, fisheries, orchards, ranchers, all those folks in the community. And we said, could we actually meet in a room? How often do you find those people even know each other's names
Wow.
in a health system? And we built a system together. So we're working on getting healthy foods to patients. And so we're actually training restaurants around to deliver food that's actually medically tailored, right? And training them what does it mean to
Mm.
make, a kidney friendly diet or a heart friendly diet. Then we are also working with the ranchers to actually source foods that are kind of climate friendly practices. And so we're helping environment and we're hiring people, we're an anchor institution that are local. So we're working with local businesses. We're not working with vendors that are necessarily outside. So you've got this whole sphere that you come together. I think that kind of breaks the traditional realm of, population health. We do diabetes care in this box
Mhm.
to say,
Yeah.
we're thinking about community elevation, we're thinking about community resilience, we're thinking about broad outcomes, health and healthcare. That I would say is probably the one I think has been a big lift, but it was just maybe it's because I'm at UC Davis. It's a big agricultural center. Maybe, it's the right people at the right time. But the mind meld happened, and that rarely happens, which is really fun. So that's a big one for us right now.
That group right there, you could do a podcast for
Yeah.
hours and hours. It's such a unique blend of perspectives
Mhm.
and expertise. And I'm curious, have you seen other, whether it's academic medical institutions that have a similar growth type of engine philosophy that UC Davis has or different, adopt a model like that? Because that is very, you're penetrating the community and community elevation, and then in part resilience for certain groups as well. Have you seen that been replicated at all?
I would say, especially in the last 5 years, because of Secretary Becerra's work, who had a big mission
Mhm.
around traditional foodist medicine and even RFK around wellness in general, there is a lot more momentum now to kind of think in these areas. But I think most of where the money's going and most of what you see published and what's spoken about is the more medical model of it still. Even though I feel
Mhm.
like most recently it's tried to think beyond that, or it's the direct patient like consumer, right? There's a product, there's a
Yes.
supplement. There's these two like bipolar areas that have a lot of growth. But I
Mhm.
think when you think about it from a community perspective, to say, where are we sourcing the food? How are we bringing the farmers? How do we bring industries? How do we combine all of this into
Mm.
one like food system? There really are not. I feel like there's less than five that I that I really know at scale that are in the country. And so
I
that's
love
really
that.
exciting work because that's when the economics come to play.
Yes.
So for example, we're working with a group. If we're negotiating with farmers and ranchers around kind of the business we're giving them to supply food for us, we're able to kind of negotiate prices and things like that. That's bringing health system money right down, right, in terms of cost to kind of
Mhm.
provide those programs. Wouldn't it be amazing if we could then turn that money back into care managers and some of these other
Oh,
programs that work on meeting social needs for patients?
mhm.
You're self-sustaining, right? Like in that model. I haven't totally gotten there locally. It's just that there's models out there that until you do it in this way with these approaches, you'll always work in your silo and everything's a cost and you never get to see how they link together.
Exactly. And I like how you're seeing beyond your siloed unit costs or your fixed
Mm.
costs that you're constrained by. And strategic partnerships outside your walls can create more margin for you to be able to do different things that cycle back to or come down to individual people and their communities. Wow. So I see the engineering side of your brain here too. And I
Yeah.
like that it's puzzle piecing from a programmatic and strategic partnership level. There's so many, and this goes back to your earlier definition of population health. There's so many different ways to view what population health is today and where it's come from. And you are truly living it. And Dr. Gupta, I want to hit maybe two more questions before we wrap our conversation here today. And one of them kind of goes a little bit back to your CMMI days. And it was interesting that you played a big role in the Defense Department on the military board of health as well. So I'm sure you saw the evolution of DARPA to ARPA, ARPA H now, and the promise of what can be. And in particular, digital health. Let's touch on this
Mm,
for a moment. So we had some good friends, Abe Sutton and others, join a month ago, maybe a few months ago, and talk about access and what that will come to
mhm,
be
mhm,
post July when they launch. And it's a very interesting model for those that aren't familiar. Cardio kidney metabolic population
mhm,
of seniors, Medicare Advantage eligible members, and how digital health can be prescribed to them to reduce healthcare utilization and improve health. I mean, I'm summarizing as best as I can. And I think you probably had early influence to where a lot of that work was starting in your experience. So do you see
mhm,
digital health as becoming the centerpiece for lifestyle behavior change with a physician's touch, or is it going to be more part of the clinical decision-making model in the future?
mm. So such a good question, but it's loaded.
It
The
is. I
answer.
went too big.
No, it's perfect. I have a multi-part answer. So I think a lot of my work with the government was with CMMI, which I think has traditionally had a very care model focused approach, which really attracted me to it. And then the work that I had with the Military Health Board was on the subcommittee for healthcare delivery. And so in that advisory group, it was very much focused on discussing implementation, like what are models that actually get implemented. So even with that, I think it's always still had that similar ethos, right, that we were talking about earlier about what really works, what doesn't fly in that care model. I think with digital health, I don't think this is controversial, but it feels controversial sometimes in some meetings. I'm not a tool person, and I think people that build technologies and platforms don't want to say they're tool people either. But there's people who are out there that are maybe executive leaders, right? That lead systems that we purchase platforms that sometimes I think are tool people, meaning it's a shiny
I
object that's
agree.
going to save me of all the cracks that are in my system. So I'm definitely not that person. I'm the person who really says that as a leader, you need a directive strategy to understand your population and your patient's needs. Within that, you need a care model that really addresses
Mhm.
those needs. And when you have that, how do you scale it? How do you make it more efficient? Right? How do you make it meet more patients? How do you make it more cost effective? That's when the technology and the platform comes in. So I don't think
Mhm.
digital is for me the thing that's going to save anybody. What that does is it tends to, and this is AI or kind of digital tools, it amplifies the problems. So if you don't fix the problems, you're just going to make them bigger, in my opinion, and more costly.
Mhm.
I think there's going to be a lot of people out there that are jumping to have like that silver bullet, and their costs will go up because these contracts are not
Yes.
cheap. I have gone through the ROIs multiple times on many of them the last few years. They're not cheap, and sometimes they're more expensive unless you're really good at rolling them out. I think what you're gonna see is a division where there's groups that are
Mm.
tool-based and they're gonna flop, flop, flop because they don't fix the
Mhm.
problem and thinks there's
Mhm.
a savior coming in from a company that's gonna fix their problems, which is not what the companies think they can do either. And then the other group is gonna say, "This is a tool for us to finally get the scale that we wanted. Now, how do we do it? What's the patient population that's
Interesting.
gonna" right, I'm gonna almost, like, repeat
Yeah.
myself. "What's the patient population that's best gonna benefit? What's the care model and the workflow to do it?
Mhm.
Who does what? What is our team doing? What are the vendors doing? What's that role definition? And then let's then sign the contract. And then let's make sure the billing is happening appropriately so that we are breaking even and it's a self financially sustaining model
Mhm.
fiscally. And then you're
Mhm.
going to get the outcome on the clinical because you got the right patient population, that denominator population accurate as well. That's what gets you through the door. So we've done that a few times here, but we've turned down a bunch of contracts and even some programs
Mhm.
because they just didn't pan out. That's what's making them flop, right? So
Mhm.
not thinking through, I think it's a leadership problem more than
Mm.
anything. And I
Yeah.
think the tools and the platforms are just going to show who's a good leader and who can make those teams come together or where the priorities are at like a board level because not every leader owns every decision, for them to execute on it.
Very true in terms of autonomy in that comment. And I think it's interesting you broke down two really important things that I see some vendors in the healthcare ecosystem selling into the primary segments that focus on the promise of savings or the experience and engagement and where the return on value will come in year one, two, three, whatever. And it's interesting because you took it down to two things. It's how you integrate into existing processes or workflows. So, how well do you implement? The onus is on both parties, but it needs
Mm-hmm.
to be driven fully through, or it won't be adopted well, it won't be in the operation well. And then the other side of what you mentioned is scale. Some leaders say, hey, this is how I can reach all of my patients or
Mm-hmm.
members, what have you, all of your people you're serving in a faster way. And here's how I can recognize value and report it to a board, what
Mm-hmm.
have you, in terms of growth metrics or savings or whatever they're being held accountable to in medical loss ratio, whatever. And I think it's so interesting that you see that relative to the leadership styles across the United States. And again, you see that traditionalist versus modern era, the strategic foundation of building the teams to know their people the best. Then you can figure out what kind of support would we need if we do need it. That you're beyond your years in that comment, far beyond your years, as the wisdom would say. So I have to wrap with this question, Dr. Gupta. So I want to look at a bold bet for you here. So if you had a bold bet to place on the future of healthcare reform, where would you put your bet here? Would it, I'm
Mm-hmm.
guessing it's not going to be in maybe digital health or wearables, but would it be in wearables? Would it be in maybe clinical trials, new gene cell therapy, different, I don't want to say different platforms, but engagement models like the Nooms of the world, or the next generation of Ormatas of the world? Where is going to be your big bet that you think is early now, but will become a staple in the future, that will pay off in the future? Any bet you would make if you had house money,
Yeah.
of course.
Okay. I'm picking three. So I
Oh,
apologize.
man, you are a gambler. Okay, all right.
No, but I think it literally will tie everything we've talked about together here. So I think that the agentic AI, and I'm sure there'll be new AI forms coming out that I'm not even remotely aware of, are absolutely a game changer. I think we're going to see leaders make a lot of mistakes for the reasons that we said in trying to implement them and how best to use them. But I think along the way, we're going to learn that population model is a way of saying it, but like what agentic AI is best used for whom and where and how, right? Like that will eventually kind of get there. And that's going to be a game changer because the resources that we put in healthcare delivery to actually be able to customize and target it to the patients that are actually going to activate it, or if we're using it even for like a internal administrative thing, to use it in a way that's actually going to move the needle. That's what's been missing in value. We throw resources at a bunch of stuff, but it's a little bit of throwing spaghetti at the wall and hoping that the right patients right get activated by that way we're reaching out. That's huge. So the real time, for example, the real time care management that agentic AI can kind of like help get real time data and activate teams to be able to target these patients at these times and these locations.
Real
That's a
time.
game changer. And there's a few companies that are starting to do that now that are really exciting. But to do that at scale, right, to have everyone do that, that's a huge area.
Mm.
I would always say social needs. I mean, the communities have needs and they're not
This is
going
bet
away.
number two we're
Yeah. And
on
my
here.
number
Okay.
two. Yeah, so being able to really invest in upstream social needs. It's like the hierarchy of needs, right? If you can't get the food and transportation or whatever,
Mm,
we can't
mm,
let an enormous part of the country just fall behind, like that.
mm,
It's just knowing where I'm coming from. That's got to be an area, the food work fits into that. And then I think the other one, which I know is not the most exciting one to talk about, but I so fundamentally think it's important, is the hardest one. We need
mm,
strong leadership in healthcare.
mm,
I don't think we have
mm,
strong leadership everywhere.
mm.
So who's
Wow.
asking those hard questions and willing to take the risks? And it's extremely hard. Everyone's working in pretty much negative marginal budgets right now. There's
Mm,
layoffs
mm,
left and right after COVID. Like every executive role is a rotating door, CEO, CFO
mm,
specifically. It's really hard. How do you lead a system when, half your leadership is turning the door
mm,
every year? It's not easy, but we have to stabilize at some point if we actually want these outcomes and investments to continue and sustain. And so that investment of having leadership maybe be the modern leadership is to use your terminology, but
mm,
people who can maybe think about how we restructure healthcare. We have a lot of money going out of healthcare right now. Maybe when we come back to really rethink, how do we set it up in a way so we're really directive in our strategy and we're meeting our community needs? I mean, it sounds obvious, but we don't do it. So
Yeah.
I think those three things could really transform a lot of what we're doing going forward.
Of your bets, I like the last. That's the most bold statement within what's not only needed, but what you're hoping is put into place is stability and strong leaders that stick to what they believe they need to improve health of the populations they serve. I am so over the moon thankful for having you on our show here, Executive Uninterrupted. Dr. Reshma Gupta, Chief Population Health Officer, UC Davis, and the amazing role and stretch you have across all UC Davis campuses in Southern California. I'm so thankful to have had your time here today.
Thank you. This is fun.